All right, so welcome back, everyone. So we're going to start our session on controversies in medical education, competency assessment reporting, pro-con debates. I probably should have mentioned this morning, but the theme of this meeting is medical education getting too right. So that's what we hope to do in the next couple of hours. So I want to introduce our first session, which is going to be Entrustable Professional Activities versus Milestones, which framework better assesses and monitors the competency of medical students and residents along the continuum of medical education. This will be debated. Carrie Chen, who is Associate Dean of Assessment and Educational Scholarship and Professor of Pediatrics at Georgetown, will take the EPA approach, and for ACGME Milestones will be Stan Hamstra, who is Vice President of Milestone Research and Education and Evaluation at the ACGME. And I don't know how they decided, but Stan is going to go first. So Stan, take it away.
Okay, thank you very much. Sound good? Okay, great. So I'm going to take the approach that we need to think about the acronyms and what they mean. So EPAs stands for Entrustable Professional Activities. ACGME stands for Accreditation Council for Graduate Medical Education. So I just want you to park that for the moment. So my basic proposition is that words matter, but more words don't necessarily matter more. Okay? So certainly, detailed milestones add value, but can the EPAs do the same that milestones can do in terms of detail? I think for a physician, for any physician, there are an infinite list of activities that may not be captured in a set of EPAs, and EPAs are also difficult for breaking down and giving people formative feedback, and that's where the milestones really shine. Medicine is complex, milestones are detailed, and EPAs are a little too generic for that. So I could finish there, but I have 15 minutes. So, or as my grad school professor used to say, eschew obfuscation. So I'll try and do that. So there is a historical context here, and that is that for centuries, medical education was underspecified, that it's a complex activity to train people in medicine, and that we needed some kind of specification because of changes in the healthcare delivery system, and we needed accountability to the public. The public demanded, in essence, that we identify and specify all of those detailed competencies that were required for physicians, and especially specialty physicians who are graduating from these programs. So these are what the milestones look like. Milestones come out of the competencies, they come out of sub-competencies. There are a median of 22 sub-competencies per specialty. As you can see, I just picked one that I'm very familiar with, neurosurgery, and it breaks it down into quite some detail. Of course, you might argue that there could be more specification in some specialties regarding some of the details under each sub-competency, but that's really a matter of editing and revision and further specification. So the bottom line here is that EPA type language already exists in the milestones. And in fact, there are very sophisticated ways of mapping milestones onto EPAs. And this is a sort of a modified slide or framework from Ola Tenkat, who is the person who came up with the Entrustable Professional Activities idea to begin with. And the idea here is that every one of these EPAs involves different sub-competencies that map onto the milestones. So in essence, these are two parallel frameworks that work in concert with each other. And there's really no distinguishing once you get down to the details. And in fact, if you look at the system in which this operates, you have residents within an institution or program, you have faculty and program directors, and others providing input. The milestones provide that guiding framework and blueprint for competency achievement. And within the culture of that institution and program, assessments are made through direct observations and other sources. And all of those gets fed into a process of judgment and synthesis that is led by a clinical competency committee, a program director, and who use their professional judgment to moderate and modify those judgments to make the decisions about competence for that individual. And in that way, we protect the public through certification or through accreditation of programs, and of course the boards do this part. But the point is that this is a human process. And so whether you're doing it through EPAs or milestones, at some point you have to take the data, and as was so articulately presented this morning, it's more important to interpret the data than it is just to have data. So there needs to be a human process involved. And whether you do it through EPAs or milestones, I think it's really the same thing. But milestones give you that data that you can then generate the entrustment decisions about. And in fact, if you have assessment tools that are well defined and well constructed, you really don't need EPAs. So here's an example of an assessment tool where there is entrustment language. So on a scale of 1 to 5, how well did this resident elicit histories from their patients during a clinic? So during the entire clinic, the physician monitors the resident's performance in all of these different dimensions and then makes judgments about the resident's performance on an entrustability scale. So I had to do it myself. I had to talk them through. It's really a 2 out of 5. I had to direct them from time to time. I needed to be available just in case as a 4 out of 5. And number 5 is I really could have given this entire clinic over to the resident. So the entrustment language in this case is built into the assessment tool. The assessment tool data then feeds into the CCC, and they can make entrustment decisions about the residents. So in no part of that system do you have EPAs specified explicitly. You can put the entrustment language into the assessment process. So in conclusion, I would say detailed milestones do add value. I wonder that EPAs can do this. I think that there are so many activities involved in medical practice, involved in medical education, that you need super specification, and that's where the subcompetencies come into play. And whether or not they represent the complexity of medicine is an empirical question, and they can be revised. And in fact, that's what we're doing. We're revising the milestones into milestones 2.0 in the next couple of years to further specify and sharpen their ability to detect and to monitor all the complexity that goes into medical education at the residency level. That makes them more effective for specific formative feedback. So in closing, I would say, think about those acronyms and what they mean. I would submit to you that EPAs stand for evidently, pedantic articulations, where ACGME stands for anyone can get medical education. I think you got to switch.
Yeah. Sorry, he's telling me to change the slides. Very important.
So first I want to say that it's nice to know that we're trying to achieve the same goal, right? We're all interested in competence. What I'm going to share with you are the reasons why really EPAs are the way forward, okay? Oh, where are the... You point it.
Oh, you need this? Okay.
Yes.
Oh, I was going to keep that.
Okay. So, and I'm going to keep this at, we're going to zoom out and go sort of larger philosophical levels here. And I think one of the things I would ask is, what is it that we're trying to achieve with competency-based medical education? And I stole this from Ola Tenkata, who presented this in Ottawa last month. And the questions are we just trying to adopt a competency framework for medical school or for further training? Okay. Are we trying to implement a framework or tools for competency assessment? Are we trying to graduate learners who meet standards, right, at the time of graduation or licensing? And sometimes I think we forget and we think that this is our goal, right? But I argue that our goal is really to deliver practitioners who are capable of coping with and providing safe quality care in the context of unpredictable requirements of practice, right, at any time during practice. And this is different, right? It isn't just saying I've adopted a competency framework and pat myself on the back, I'm so proud of myself, right? Is, are we really achieving this? All right. Now, the critics of competency-based medical education, you know, one of the largest criticisms is that it's too reductionistic, right? By breaking down the competencies into competency domains, subcompetencies, and milestones, is that we've atomized it. And when we take those pieces and add them back together, they don't necessarily add back to capture the whole of practice, right? So, you know, just because you can, when we demonstrate patient care competencies, we don't do it in isolation from knowledge or professionalism. They come together. And in fact, when we measure that someone is able to do a subcompetency around patient care or knowledge or professionalism, it doesn't guarantee that that learner will be able to integrate that and apply it to a patient in practice. So the EPAs offer a more holistic way of, and actually it allows us to look at how people integrate and apply those competencies and how they actually do it in practice in caring for a patient. Now, one of the questions you might have is, well, the beauty of milestones is that it gives us a developmental framework, right? It gives us benchmarks to allow us to look at progression. So how do EPAs do that? One of the things is that we want benchmarks in the EPAs as well, but the way to do that is not to break it down into these individual competency areas, but to break it down into smaller activities, right? And so what we do is you create smaller activities that are more focused, less complex, right? Where you control the context, and then they nest up into larger activities so that your initial EPAs are foundational for the future ones. So for instance, for a first or second year medical student, when I say entrustment to take a history, it's for a patient that is probably medically stable, right? In no psychological or medical or physical distress, right? Probably an adult who's cognitively intact and hopefully a nice cooperative adult, right? And then we begin to broaden that and expect more as we go up. So we have EPAs that are larger breadth. And we look at the AAMC 13 core EPAs. They provide the foundation for then what we need at the GME level for GME EPAs. And the concern is that when we focus so hard on what is measurable, right, and that I think the psychometricians in all of us want the little pieces that we feel like we can be very objective, separate it out from context, we can measure it, I can feel good about the reliability of that measurement, is then we begin to lose maybe what's actually important. So the second reason why I think EPAs are a way forward is that they link the idea of supervision and entrustment to assessment, right? And so I like this idea of anybody can understand medical or get medical education. So I will say that I used to be in charge of a clinical skills course with over 400 volunteer faculty from the community. And they hated us, right? Every time we said, oh, we need you to evaluate our students in these competency domains, and there's, you know, what is this edu-speak, right? What are you saying? And then when we piloted EPAs and said, I just want you to get the student to the point where you can leave them alone to do a history and physical on a patient with a simple chief complaint. And they understood that. And at the end of the first or second year, I said, okay, you're going to transfer them to a new preceptor. What would you say to the preceptor that you would trust them to be able to do with you outside the room? And again, they understand that. So I would say, actually, that anyone can get EPAs. And these are decisions that our supervising clinicians already make every day, right? When they're thinking about who am I going to send in to see this patient, is they already do that. So we say instead of having to think about another scale, let me just ask you, like, what would you trust this learner to do with what level of supervision? And I think for me, even more importantly, is that when we think about competency-based medical education, we want to advance our learners when they demonstrate that they are ready. And the beauty of EPAs, again, is we have defined activities. And we say to the learner, okay, when you are ready, I'm actually going to take off the training wheels. I'm going to decrease the level of supervision and give you more autonomy and maybe have you work on a larger EPA. And this is incredibly empowering, and it's very clear to the learner what their goal is they're heading towards independent practice for a specific activity. And it reminds the faculty that we do need to advance their responsibility and give increased autonomy as they progress. By having nested EPAs, very small EPAs, even our very early learners, first and second year students, can be given activities to contribute to patient care. The third reason, this is my favorite reason, is that EPAs highlight the consequences of assessment, right? We place patient safety front and center when we ask, do you trust this person to do this, and with how much supervision? Now, I often use driving as an analogy, right? So if you ask me to rate the teenager who lives next door to me, how good is their driving on a scale of 1 to 5, or even using the OCAT tool that Dr. Hamstra showed, which is, did I have to step in? Did I have to sit in the driver's seat? It's very different than asking about entrustment. Would it be different if I said, do you trust this person to take my new car out? Would it make a difference if there was a baby in the back? Would it make a difference if the baby was the last Jedi? Okay. And I think that that's important when I say that it takes into account trust and entrustment. So I think there's a subtle difference between a supervision scale and an entrustment scale, and we shouldn't lose sight of that, right? When we use just a supervision scale, it's easy to fall back into thinking that EPAs are just activities and we only need to focus on the ability to complete that activity. But in fact, entrustment scales are about trust and trustworthiness. This means that someone doesn't just need the ability, but they have to be, we have to know that they're reliable, that they're conscientious, that they don't have extreme good days and extreme bad days, that they show integrity, they'll tell us the truth if they haven't done something, that they have the best interest of the patient at heart, and that they know their limits and will ask for help if they need it. And again, this is a difference, you might argue, oh, well, we have professionalism as one of our competency domains, and we have lots of sub-competencies around that. But the danger of that is what faculty will tend to say is, oh, but this person has done so well in all of these domains except professionalism. And it's easy to sort of say, well, this is just one thing that we need to work at. Under the EPA framework, it's without trustworthiness, you cannot be entrustable for any integrity. Right? It is the baseline. That we need that for everything. And then the last thing, I think actually the most important thing that changes how we think about assessment is that it looks forward instead of backwards. Again, the OCAT scale is, I had to do X, Y, or Z, right? But I'm not asking you what you had to do. I'm asking you to think forwards. And it forces you to think about, again, all of these other issues around, will they ask for help when they need it? Will they recognize when they're out of their depth? Okay? And as part of thinking about future performance, I want you to look at this. This is, I made this up. This is a performance of learner 1 and learner 2. And what we tend to do in our current assessments is we ask, what is the average competence of this learner, right? We sample 10 times, and if you mathematically, learner 1 and learner 2 have the exact same average. But qualitatively, they're different, right? If we say 0 is minimal acceptable, and anything below that is dangerous for patient care, the story is now different. So really the question we ought to be asking and always be asking is, how big is the risk of this learner performing seriously below standard in a future case? And this is why it's so important to be focused on entrustment for future activities. Whereas you might be comfortable graduating both learners 1 and 2 based on an average, I always say it's a very different. We feel much more comfortable about having learner 2 take care of my mother than learner 1. And that is why EPAs really are the way forward.
Okay, so in lieu of Q&A, we're going to have a 5-minute rebuttal on each side. And the idea was that I know that you're all really, you have a lot of questions burning, but you're supposed to take those to the breakout groups afterwards, okay? So my rebuttal, I think there's a lot of common ground, first of all. But I think that it depends on where your faculty are in their sophistication around education, their engagement and buy-in into the assessment systems within your program. I can imagine a general surgery program that I will not name, but I know. And I go to those faculty, and if you tell them that they now have to think about EPAs in addition to milestones, there will be a revolt. So it's just more edu-speak for them. So rather than imposing more edu-speak on people who haven't already taken this up, I just propose that we build tools that they can use more intuitively that amount to the same thing without layering on the edu-speak of EPAs. So in fact, what we're doing is building in micro-entrustment decisions in the formative processes of education to feed into a macro-entrustment decision at time of graduation without burdening them with yet another framework. Having said that, I think that if you have a culture in a program or within a specialty like pediatrics who've fully embraced EPAs, then that's fine. I wouldn't say take them away. I think there's something value added there. But what I'm saying is that I don't think we should just buy into the EPA concept without that kind of consideration. Because what happens in practice, that slide that I showed you where you're mapping the EPAs onto milestones, we're all interested in education. So we look at that slide and we've heard Tenkata speak before, and we kind of get that. You can map EPAs onto milestones backwards and forwards, and you can think about what milestones are achieved by a certain EPA. But that's really back office work. That's something that you need people with some training in education to dedicate themselves to. The front office work of the faculty rater, I don't think they should be concerned with all of that mapping and thinking about what's a milestone and what's an EPA and what's a construct and what's a task and what's a subcompetency. I think you're right. I think they need some kind of simple entrustability scale to use it in terms of an activity that makes sense to them intuitively. And then we collect that data and do the back office work of mapping the EPA data onto the milestones. So I think it's not that simple. I think that you need to have either a culture that's already bought into it, or you need to have resources or a system that does the back office work to support the front office work. And Peter Katsifrakis told me the other day that we really also probably had to have a mid-office somewhere in there that translates between those two, stats geeks in the back office and the frontline faculty. So I like that idea a lot. So yeah, I would just focus on those two things, that there's a difference between formative micro-entrustment decisions for the purpose of giving feedback and improvement, and those really important last Jedi entrustment decisions that you need to make at the end of training. So, and then this front office, back office notion.
So I know we were supposed to be at our extremes, but I think you're right, and I sort of want to come towards the middle a little bit, because that's the reality in which we live, and for you to then problem solve later on, it's useful to think about these things. And I do think that it is hard when we've spent so many years with the faculty on the ACGME competency domains, and we've done all this work in developing the milestones, and at the GME level at least, they're already working on the reporting milestones. So just to add on a whole other layer, I think is very challenging. Now, I think on the UME end, though, there's a little more freedom because the UME hasn't been using milestones necessarily. Most schools haven't. Most schools have their own competencies, in fact, that aren't necessarily mapped to the ACGME competencies, and that gives you more freedom. And that's what we see in Europe and in other countries is that, because they hadn't previously done work around the competency domains or milestones, is that they don't have to be tied to that. And you have the freedom to then use your EPA framework for everything and have nesting EPAs. What's interesting here, I think, sort of the back office, front office, is in my personal experience working with faculty, so when faculty struggle with a learner, some faculty who've been more involved in education work can tell me what the issue is. Other faculty aren't. They just say there's something wrong. And then, in fact, I have to sit with them, and then we break it down, right? And so this might be sort of so do we try to educate all the faculty on these different subdomains and these milestones, and then we measure milestones and make an inference about whether someone can bring all that together to practice? Or do we have faculty pay attention to practice, tell us when there's an issue, and then our back office work is to break that down to figure out where the problem is and how do we remediate? So different ways to think about that. And so one way to do that is to say, well, we can adopt the EPA framework, use that as the front office work, and really the people who are versed in education do the back office work in trying to break down when there is a problem and looking at, so where are we in all of this? And what Bob Englander does, as you mentioned, pediatrics has really embraced the EPAs, is they've taken all the work that was done using the milestones and used the milestones to help build a picture of what that learner would look like at different levels. Because regardless of which model we use, we need a shared mental framework. And so he uses that to help build the shared mental framework. So I do think that we can take advantage of the work that has been done, but I think it's worth thinking about what should be front office, what should be back office.
Great, thanks very much. Okay, I'd like to ask our next presenters to come up. Actually, before I do, it just occurred to me that if Carrie had left the podium and walked behind Stan, she would have disappeared. So you would not have even seen her. But anyway, so if we could have the next folks up for the debate, who will be Catherine Lucy, who is, well, the title of this debate is, let me actually get them hooked up. You both have slides also?
Yes.
That one? Okay, great. Hold on, give me a second here. So what you need to do is... Yes.
And we need.
So this next debate, and the clicker is on that podium.
Oh, okay. I'll take.
So the next debate is around USMLE scoring and reporting. Should the USMLE results only be reported as pass-fail to remove the score as a barrier to innovation, medical education, and competency-based assessment? So taking the pro will be Catherine Lucy, who's Vice Dean for Education at the University of California, San Francisco School of Medicine. And taking the con will be Michael Barone, who is Vice President of Licensure Programs at the National Board of Medical Examiners. So Catherine is going first.
Thank you. So those of you with a short attention span, this is the message. Just to justify my presence here, especially since I'm in the shadow of my esteemed colleague over here, I just want to comment that in my career, I have actually participated in every part of the ecosystem that I'm about to talk about. I have been a residency program director receiving thousands of applications for residency program director. I've been a vice dean for education sending out those applications. And I've been involved in high-stakes testing, high-stakes exam testing, both exam development, scoring, standard setting, and score distribution at both the AAMC for the MCAT and the American Board of Internal Medicine for the certifying exam. So all of us in this room and collectively in our ecosystem of education and assessment want the same thing. We are charged with medical education as a public good. That means we are responsible for creating the workforce that we need to deliver care to the 21st century patients. And that includes a workforce that's diverse as our communities and is fully versed in all of the competencies we think are essential for high quality health care that's equitable, safe, fair, and patient-centered. And it's also important for us to make sure that we're creating citizens of the world and citizens of our profession, those who are thriving, ethical, and well enough to carry out the work that they need to do. Our tools in our ecosystem as academic institutions, whether we're schools of medicine or residency programs sitting in our schools of medicine or in our community teaching hospitals, are the educational programs that we design and the students and residents that we admit. And for standard setting organizations, such as the NBME, high stakes, rigorous, psychometrically valid exams are the tools that we use. But like any ecosystem, a decision that we make has downstream consequences on the other aspects of our ecosystem. And the flapping of the butterfly wings in the NBME with the decision to release scores as scores rather than pass-fail has had the same hurricane-like effects that we have seen in other ecosystems when butterflies flap their wings in the wrong direction. So for those of you who are just waking up and will need to hear things twice, I'm going to give you my conclusions now. That might be me. And it's important, these are the conclusions I'm going to hope to convince you of in the next couple of minutes. The validity of standardized exams, high-stakes standardized exams in particular, resides not only in psychometric integrity and isolation, but the ways in which those scores are used. That is the actual validity that we should be thinking about. The USMLE, in my view, is a measure of achievement, but instead is used by residency programs as a measure of aptitudes. Fully 2/3 on average of residency program directors use Step 1 scores to screen out applicants to their residency program, and more for the more competitive specialties. This misuse of the USMLE is facilitated by the reporting of numeric scores rather than a pass-fail decision, and this misuse contributes to many downstream consequences. The hurricane we are dealing with is student stress and distress, a hindering of our educational innovation. It undermines global competency development in our individuals, reinforces inequities in educational and career-based opportunity for our minority populations, and thus is threatening our commitment to the public good. So what is the purpose of gateway standardized exams? And this is where the conflict in our environment exists. There is a group of individuals, I think most of us, who believe that these are achievement exams. And when you get a score back, a decision based on your exam should tell you keep going. Based on what we know about your learning to date, as measured on this particular day, we think you are good enough to keep going. They are open-door exams that continue people's trajectory towards the career they aspire to and the licenses that they will need to have in order to serve patients going forward. If we view it as aptitudes, however, very often the message from the exam result is stop. Based on the information we have about your progress and achievement to date, we don't think you're ever going to be good enough to pursue some of the careers in medicine. And in fact, this is the operationalization of a decision by our residency program directors, and I'm going to say our, because as a vice dean, I have responsibility for those residency program directors when we allow them and encourage them in some ways by the releasing of numbers scores and numbers to make this decision that this individual is never going to be good enough. But let's look at the potential reasons why they think this is true and make our decision today. So face validity is the first question. Does it seem fair on face value to use the USMLE Step 1 score as a measure of aptitude? Well, here are the stages of a career. Undergraduate medical education, 130 weeks is about 8,000 hours. Graduate medical education, a 4-year training and duration is about 16,000 hours, and a career is about 90,000 hours. So I asked the question, is it fair on face value to use the USMLE Step 1 exam, which occurs about 3,000 to 4,000 hours into this 100,000 plus trajectory. So exam results from 8 hours of performance as a aptitude assessment of whether or not you will continue learning throughout your career and could be successful in any career that you choose to proceed. But face validity doesn't necessarily tell the story, so what does the literature tell us about whether or not it is supported to use these exams as aptitude exams, and that is as exams that exclude people from certain careers? There is an exhaustive literature, dozens and dozens of articles from every single specialty that attempts to justify the use of USMLE Step 1 as an aptitude exam or as a screening exam for residency interviews. And in what I would call newsflash, water is wet, scores on standardized exam predict scores on subsequent standardized exams. I don't think we need to test this anymore, and I would suggest that not be the focus of any of your scholarly activities. But importantly, those scores do not necessarily predict as well other subjective ratings like faculty ratings of student performance or clinical performance in the environment. And the best article I would point you to is Susan Kenny's article in MedEd. Robin Tamblin's and Elizabeth Wenghofer's work looking at the Medical Council of Canada qualifying exams have given people encouragement to use these exams as aptitude scores because they do demonstrate in Canada that lower scores on the Medical Council of Quality qualifying exam do somehow correlate with lower scores in practice, and they've done some really elegant studies on this. I'm going to point out a couple of things about why we should be careful about taking that correlation as a causative issue. First off, it's in Canada. Nothing more needed to be said. Secondly, they're better than this in every possible way. Secondly, the qualifying exam is taken at the end of medical school, not in your second or third year in medical school. And lastly, and this is most important for us in Step 1, Step 1 exams actually cause a conflation here because Step 1 exams allow you entry into the most elite programs. And we know that residency program quality predicts quality down the road. So it may not be the Step 1 performance on year 2 or 3 of medical school is providing better quality. It's that performance that gets you into a higher quality residency program that then teaches you to provide better care through the rest of your career. So correlation does not imply causation. Some of the most interesting work that's come out of the National Board recently is from Cuddy, and they demonstrated with colleagues that higher Step 2 CK scores correlated with lower rates of board discipline. Very interesting literature. A couple of important things I will point out. First, this was 15,000 physicians, 1% of whom had discipline. So we should think a little bit about the number needed to treat. Secondly, I would say, really interestingly, that Step 2 score, 10 points over the median, decreased your rate of medical board discipline by 25%. If you were a woman candidate, that decreased your rate of medical board discipline by 50%. So another way of saying that is if you're a man, you have to score 10 points above the median to have as low a rate of discipline as a woman who scores 10 points below the median. So you can choose which direction you want to go in here. But again, what we're talking about is ferreting out an additional 3,000 physicians out of a population of 750,000 if we use Step 2 CK. And if you use Step 2 CK, it actually undermines, there's no value of Step 1 in predicting poor performance by medical board, as evidenced by medical board discipline. So fine, we don't have strong face validity, we don't have strong literature-based validity or empiric validity, but if there were no negative consequences, we could get away with it. But there are tremendous negative consequences in equating USMLE Step 1 with aptitude. It stands in the way of our commitment to use medical education as a public good. The wellness to our students I've already talked about, and I think all of you feel with your students, the stress they have around this particular exam, and the dejection they feel if they don't score high enough. We have students who would prefer to fail Step 1 so they can try for a higher score than get a mediocre score on Step 1. Any test that focuses our students' attention on global competency development as evidenced by their test minimizes their interest in pursuing other parts of competency, inquiry, emerging scientists, interprofessional teamwork, and the like. But I want to spend just a minute talking about the really chilling effects that this exam has on diversity and equity in our residency programs and in careers like academic medicine. Step 1 correlates very strongly with entry into the most competitive and, I might say, most lucrative careers. It also, the residency programs that screen most strictly have the worst diversity. In addition, academic medicine, as work done by Andrea and colleagues has shown, is much less, people with low Step 1 scores are much less likely to pursue academic careers, and it may cause all of us to struggle continuously to diversify our faculty. Now, why does that exist? Why is there such a strong correlation between diversity and Step 1 scores? Well, in every single standardized high-stakes exam that exists in America today, starting with SATs and going forward, there are population group differences between majority and well-represented in medicine and underrepresented in medicine in groups that always favor the well-represented in medicine groups. So you can count on the fact that your underrepresented in medicine will score slightly less, slightly lower than their well-represented colleagues. And this isn't a reflection of bias in the tests. They are psychometrically sound. And it's not a reflective of aptitude of the individuals who are scoring slightly lower. What it reflects is a slightly lower rate of achievement that is based in structural racism that has negatively impacted the educational quality of K through 16 education, and we are dealing with the consequences of that. And what we have seen at UCSF is that over time in a highly structured, rigorous, but supportive program, the gaps between those population groups, well-represented, underrepresented, narrow steadily. The gap in Step 2 CK is much less than the gap that we saw. So this is a question of fairness when we think about, are we caring about achievement that happens quickly, or are we caring about achievement that happens before the next stage of their career? And Prober and colleagues have talked about the educational impact on the chilling effect on educational innovation. Now, I know that fulfilling our commitment, and you do too, to the public good is going to require more than shifting from numeric scores on USMLE Step 1 to pass-fail scores. But we can't fall prey to the question or the assertions that because we don't know how to deal with large volumes of application, or because we don't know how to get people to stop using high scores to measure the success of their institution, or to stop residency program directors if we don't give them the USMLE Step 1 from using MCAT scores to select those. Because we don't know those questions, the answer to those questions is no reason to continue a divisive process. In fact, it's the exact reason why we should be willing to disrupt the environment by creating another butterfly wing flapping, and that is shift back to a pass-fail report for USMLE Step 1. And let's work together to answer all of the questions and consequences that may result from that decision. But that's a decision that puts our students right in the center of keep going, you're good enough, as opposed to stop, you'll never be good enough. So as I said at the beginning, medical education, I firmly believe, is a public good, and it is important for us to take the first step. Martin Luther King said, take the first step. You don't have to see the way all the steps on the staircase. Don't be afraid, just take the first step. We have to realize that the way we represent the results of tests is causing them to be used in a way that's counter to every single one of our educational principles that we believe in, and to the health and well-being of not only our students, but of the medical profession going forward. Thank you.
Well, good morning, everyone. Thanks, Dr. Lucy. That was spirited. I have no disclosures. I am an employee of the NBME, and I promise the only training I've done for this talk is running up the steps of the Philadelphia Museum of Art 6 or 7 times and going like this at the time I got to the top of the steps. So, I'm Michael Barone. I'm a pediatrician, and I serve as the program lead for USMLE. And I am going to take the con position here, and I'm going to try to frame my talk particularly around how it might relate to competency-based time variable education. So I realize that I'm probably not speaking about the favorable position today. I will refer to some notes because I have a lot to say. But I would like to make sure that we don't actually disintegrate these two arguments. In other words, can USMLE remain to be scored in a competency-based time variable format? First, I want to start with some things that we have in common. I agree with many of your points, actually. The National Board thinks competency-based time variable education makes a lot of sense. We know that there'll be problems with scaling, as I'm sure you all are working on, but it doesn't seem possible not to move forward with this. The board also has many, many activities outside of USMLE that really support formative assessment and workplace-based assessment. And lastly, the NBME, or the USMLE program in particular, its parent organizations, its governance committees, many of you actually participate in that, very much recognize the problem with the secondary unintended use of the USMLE score, something that some have referred to as off-label use of the USMLE score. But is the 3-digit score really hindering the advancement to competency-based time variable education? I would say no, given that there have been many, many advances already made in this area and many successful pilot projects that you're all showing. So as this audience knows, USMLE has a primary purpose supporting 2 inferences, largely signaling that to the state boards. And those 2 inferences are readiness to practice in a supervised setting, and then subsequently readiness to practice in an unsupervised setting. And while we do report those 3-digit scores on the multiple choice versions of the assessment series, we don't dictate how those scores are used. Most of the problem surrounds that very, very challenging transition of UME to GME, that residency selection, as has been discussed. So what I'd like you to do is think about how much of a hindrance that 3-digit score is, or actually could it be an asset to an overall system like this system we're here gathered today that's transitioning to time variable training? I.e., is it useful as a means of precisely measuring something with accuracy and precision simply as an input into an entrustment decision or whatever at a time of that transition to a time variable system? Not meant to be used in isolation, but whether it can actually coexist with competency-based time variable education. One way I like to say it is that you wouldn't necessarily throw out a very sharp tool just because that sharp tool has some disadvantages, like it can cut you. So said another way, what will we be giving up if USMLE went to pass-fail? And what I'd like to do is just focus on 5 parts of USMLE that I think are worth considering in this very important decision. So the first are competencies, arguably the most important aspect of what we're speaking about at this meeting. Our USMLE content outline is a competency-based outline relevant to physician practice. Since a re-examination of the program a number of years ago, we've used the ACGME competencies as our scaffolding. It's important for us to remember in this room that the USMLE program of today is not the USMLE program that you remember. Gone are all the factoid questions that simply suggest recall or test recall. The program has actually made significant advances in testing an examinee's ability to use data to make decisions and to test clinical reasoning. All told, USMLE consists of meaningful assessments in at least 4 of the 6 ACGME competencies: medical knowledge, patient care, systems-based practice, and communication. And outside of the global evaluations we do in medical school, which are subject to many, many challenges, particularly in reliability, most medical school assessments rarely encompass all of these competencies at the same time. Well, how about rigor? I think this was referred to already. A former president of the National Board, Dr. John Hubbard, used to say this quote, "To measure ever more precisely that which is important." So if USMLE is among the few assessments that actually has that precision, are we really prepared to eliminate the scores associated with that? Most medical school assessments aren't created with rigor. In many cases, test blueprints don't even exist. Items are irregularly, if at all, examined in a review committee. Their item analysis is infrequently performed, and certainly validity studies are not conducted, even though, as you say, the validity studies have some challenges. Most medical school faculty feel very deeply about their students. I was a former student affairs dean. I understand that completely, but it certainly predisposes our assessments to multiple forms of bias, in particular things like halo effect and recency bias. So there exists also a literature basis on medical school culture of failure to fail, calling into question some of the validity of medical school assessments entirely. So as a result of all this, isn't it important that we actually maintain in this transition to time variable education some measure of national comparativeness? This could be critically important at this change in paradigm. Well, how about validity? I'm not going to go over the studies. Actually, my colleague mentioned many of the studies I would have mentioned as well. Those from the Medical Council of Canada. There is an important study that was done with our colleagues at the ECFMG in the Foundation for International Medical Education Research, looking at U.S. practicing physicians who graduated from international medical schools and showed that scores on licensing exams were inversely correlated with cardiovascular mortality of their patients. Again, not causal necessarily, but certainly a correlation. The other thing I'd like for us to consider is that USMLE is the single path to licensure within the United States. And it's important to consider, while USMLE may be imperfect, it has created an equitable form of evaluation across medical schools of different levels of prestige and different years of existence. The three-digit score report more readily enables those students, the high-performing students from those less well-recognized schools, to actually compete in a competitive GME environment with those from more prestigious or well-established schools. This is why program directors lean to that score for some national level of comparison. So some have argued that the USMLE program's score actually has created a bit of a meritocracy. And while it may seem a bit off topic for a meeting about U.S. medical education, it's important to remember the role of USMLE in assessing those students who don't train in the United States. Fully 40% or more of our USMLE takers are international graduates, and that three-digit score allows IMGs to be competitive in a very competitive GME system. Okay, this is my best joke right there, new Coke, so it doesn't get any better than that. How about the likelihood that an inferior substitute would develop? Well, as a result of the educational handoff being flawed, and until competency-based time variable training demonstrates the proper research, the market is certainly going to demand some level of comparison for candidates for residency. Absent that three-digit score, another assessment will almost certainly be created to fill that market void. The market will demand it. Imagine program directors, as was mentioned by my colleague, directly asking applicants for residency for their most recent Kaplan USMLE prep score. That's something that we actually can control, and it's something that's likely to happen. These measures, or in some cases these products that may develop, will almost certainly be of lower quality, lower trust, lower rigor than USMLE, and they will almost certainly be scored. The newly developed assessments have the capacity to increase cost to students, increase burden of test preparation time, and probably increase the overall demands in transitioning to residency. And further, those assessments as well may be unfair to certain demographic groups, something that USMLE takes very seriously in our test fairness agenda. My last point is asking you to consider your views on how assessment drives learning and how the end product of learning, i.e. knowledgeable physicians, is consistent with our contract with the public. As someone who spent quite a bit of time on the curriculum side, I think this is an important component of the discussion. We know that inclusion of content in the licensing examination series can actually drive curricular excellence, or at least curricular presence. I would point to our experience with the clinical skills examination in step 2 as a way that a rebirth of clinical skills education happened in medical schools. It's quite conceivable that in some UME programs, the drive to obtain an acceptable three-digit score is a motivating factor for curriculum excellence and, more importantly, for students' learning. The public demands knowledgeable physicians who can reason through information. If a test promotes this, isn't this meeting our contract with the public? So it's conceivable that the existence of that 3-digit score report has been a major factor in challenging students to develop excellence rather than just mere competence. This is a diagram developed by Dr. Lucy. It's one that I've used in my own teaching in clinical reasoning. Some people recommended I didn't do this. Yeah. But I think this diagram is excellent. It's a pictorial representation of an illness script, the manner in which cognitive scientists say physicians store information about conditions. Said another way, a way of describing a condition or a malady. In my field of pediatrics, how I might store information about croup, ITP, or some other diagnosis. I'd like to posit that the 3-digit score of USMLE has been considered by many to be the condition, the malady, the diagnosis that hinders medical education's nimbleness, innovation, or reform. In this case, the move to competency-based time variable education. It's not. It's far more complicated than that. Rather, it's the current state of that unintended use of the score that is often pointed to as the symptom of the transition from UME to GME. In an analogous way, that maybe a fever is not the condition itself, but rather a sign or a symptom. As I mentioned earlier, a great deal of change has already occurred in medical education since the inception of USMLE. If not, medical education would look exactly the same as it did in 1992. A number of schools have undergone curricular transformation, and some of these schools have actually partnered with our program in analyzing how their curriculum change has produced greater readiness and, in some cases, better performance on some components of the licensing exam. Our Canadian colleagues have actually made advances in competency-based medical education in the face of a scored medical licensing exam. In fact, their clinical skills exam is scored, where ours is pass-fail. So the solution isn't the elimination of a highly reliable, highly valid measure of medical knowledge that actually tests clinical reasoning, communication skills, systems-based practice, but rather a way forward on appropriately weighting its strengths. And it's also the hard work of developing additional assessments that rise to the level of importance and trust that USMLE has earned with many stakeholders, in particular the GME directors. Some of those efforts might include standardized interviews, as is happening in the AAMC pilot, nationally comparable measures of characteristics that program directors find important, like leadership and other personal competencies, further efforts on the accuracy and representativeness of the MSPE, and then finally, as was mentioned by my colleague, the release of program-specific data so that students can actually make informed choices about where they're applying for residency. And while it's not part of my main thesis today, I did stick to the extreme. I also think that creative solutions about targeted and/or timed release of 3-digit scores have potential as a way forward. So I hope that as the conference progresses, we can creatively think about how to best maintain the optimal features of both competency-based time variable education and the accuracy and precision of 3-digit score reporting. I hope to engage in some great discussion about this.
Thank you.
Dr. Lucy, your rebuttal.
So I would, first off, congratulate. It's always good to have your counterpart slide put in your slideshow. That was really slick. Note to self. So I would say, actually, I'm a big believer in the importance of standardized exams. We owe it to our public to actually demonstrate to them that our physicians have, in fact, mastered a certain level of competency. And you are 100% right that the rigor that is available to standard-setting organizations like the boards and like the USMLE is imperative for us to continue to support and to use those products to make sure that we aren't sort of falling prey to a halo bias on the students who are really passionate about and the medical careers that they aspire to. So I'm not at all actually averse to continuing the USMLE. I think it's been tremendous, and I actually would applaud the innovations that the USMLE has undertaken in the last decade to really accelerate their work towards testing the competencies that we need. Merely what I'm talking about is the idea that, in fact, a licensing exam, which by definition is a threshold exam, can be released in a scored manner. And that scored manner is actually what's causing more of the problems. We use NBME shelf exams in our environment. We use the comprehensive basic science exam in our environment just to make sure that we are pushing the students to achieve what they need to achieve to eventually be successful. So I think, like with Carrie and Stan, we are not very far away on most of our critical elements. What we are both aspiring to is the ability to use an exam for the reasons it was intended and to protect against the misuse of an exam that, in fact, in many ways is standing in the way of other important goals in the medical education and patient care environment. So with that, I'll turn it back over to Michael and hear what he has to say.
Great, thanks. So I do think we have many points of agreement. Let me mention a few things. The validity studies, the predictive validity studies that are done on standardized examinations, USMLE being an example, I think are subject to criticism. It's always important to remember what USMLE is intended to do. Some of you may sit on your state medical board and are vexed by some of the problems in professionalism that lead to state board actions. So while the number needed to treat is certainly high, as you mentioned, the state boards are desperate for anything that will give them a signal into how to predict the behavior of this person. It's a very, very complex thing. Obviously, there are many, many points along the way, but they take those studies very, very seriously, even though I think medical education takes a different view on them. I wanted to go back to your point of view on we shouldn't tell people to stop. And I, as a medical educator, feel that's not our role. Our role is to encourage, of course, but I also see a pass-fail decision versus a 3-digit score decision as a potential way of telling somebody to stop. And ultimately, in our contract to protect the public, there may be times where we do not need to tell people to stop. I think on the med ed side, all of us have had to grapple with that, where somebody who is just very well-meaning and one of the nicest people you've ever met is probably not fit for the profession. I did have one more comment. Oh, and I wanted to talk about lower scores in demographic groups. And just to let you know, some of you who have actually talked to me about this in the program, about how the program deals with this, and then in particular if our clinical skills exam is looking at this as well, not a topic of discussion today. But I think that that's a very, very serious issue for the goal of creating a diverse workforce. Again, that might be something, particularly since the information is known. We're about to actually publish this to show what that difference is. So I think any program director could take that into account as he or she sees fit. But that issue would also be an issue around the pass-fail cut point, so that if it is a systemic pipeline issue, it's going to actually show up in a pass-fail cut point because the standard is certainly not going to change for different demographic groups.
Great, thank you very much.
Yep.
Catherine, I think we need your microphone. Thanks. So our third and final debate is going to be on competency reporting before residency. When should information on the competency of medical students be provided to residency programs? And the debate will be, if our debaters could come up, David Henderson will argue before the match by the medical student performance evaluation. David is Associate Dean Student Affairs, Multicultural and Community Affairs, and Associate Professor of Family Medicine at the University of Connecticut. And before the match by the MSPE, as well as after the match by institutional specialty specific means, will be Helen Morgan, MD, who's Director of the Comprehensive Clinical Assessment and Residency Preparation Courses and Clinical Associate Professor at the University of Michigan. And who's going first? David? That's yours?
I think, yes, that's mine.
That's yours.
All wasn't sure if we would have mics. I was just planning on screaming the whole time. But I should say that Dr. Tunkel admonished us that we should not sort of stalk each other. But he didn't say anything about hacking emails. So if your slides aren't quite what you planned, has nothing to do with me whatsoever. Nothing at all. Let's see here. I think I'd like to begin by just going over a little bit of the history of the MCAT. And I'm sure many of you know this, the MCAT, the MSPE. It's undergone a number of renditions over the years. Back in 1989, the AAMC created a committee to try to create a more standardized format for what was in the Dean's Letter. And then 2002, there was another reform group that was essentially commissioned to do another refinement. And then most recently in 2014, the current format was created. And I think most schools, some schools adopted the current format 2 years ago. I think most people were on board for it for the residency application cycle this year. And it, again, one of the focuses is to create a more standardized letter to improve the transparency, or at least the perception of transparency, because I think the letters are transparent, but there is the perception that they are not particularly transparent, because there is some mistrust between student affairs deans and program directors. Why, I do not know. I think I'm pretty trustworthy looking on it. Also to improve the documentation of competency-based assessments, particularly presenting comparative data in a format that's easy to digest. And so, in most instances, form should follow function. And so the function of the MSPE is what is outlined here. And it's not a letter of recommendation. It's meant to be an objective summary of students' academic performance as well as their personal attributes. It should contain comparative assessments so that program directors have an idea of how student A performed versus their peers. And it should not be a work of creative writing. It should be based on existing narrative assessments as well as quantitative assessments. And it should be relevant to issues that are important to residency training and program directors. And from a form perspective, the form has changed a bit in this last rendition. The identifying information is really just a header for the letter. Noteworthy characteristics used to be like a page and a half or two when they were called unique characteristics. Now that's been reduced to 3 bullet points, which really makes it, why bother, but that's okay. We still put them in there. The academic history is much the same. It includes matriculation and graduation dates, leaves for whatever reason, for another degree, research, medical, personal, any remediations, including exam failures, and any sanctions or academic actions. And so that's just basically sort of a very brief summary of a given student's experience. And the academic progress is really the meat of the letter. And it contains summaries of narratives of clerkship and as well as preclinical course evaluations to the extent that they exist across formats and different curricula. As well as information on professionalism. All that in the new format is presented with sort of graphic comparisons of the student for whom the letters are being written and others in the class. And then the summary part is where the creative writing can come in, because we actually sort of do get to do that de novo within the structure of the institution, and then just general information about the way the curriculum's set up, the grading system and policies, et cetera. So, what's good about the MSP? It's really a narrative form of the student's transcript, and it's a nice companion to the transcript because it gives some texture and another dimension to what is otherwise fairly two-dimensional. And it really is comprehensive. It should contain information from both that's both qualitative and quantitative about students' performance, again, comparing them to their peers. It's been reviewed and reviewed. It is under, I think, constant evolution to the extent that sort of relevant to the conversation about EPAs and milestones. Schools that are incorporating EPAs and milestones into their assessments, these will actually become part of the MSP going forward because they're a formal part of the evaluation system. So that's what's good about it. It's actually pretty comprehensive. This is my alter ego, Donna. And you may wonder why my alter ego is a 6-year-old blind girl, but that's okay. We all have to have some range. But Donna will come back during the editorial comment at the end, because Donna tends to speak more plainly than I do. But just so to summarize, MSP is comprehensive. It includes data that encompasses the entire educational experience of the student, including personal attributes. Information fourth-year rotations is generally not part of it anymore. Sort of back in the day when I started my student affairs role, we did have some fourth-year rotations in the letter, but they have largely been excluded to some extent because they were not particularly valued as much as third-year rotations, and also the structure of the application process changed such that the letter used to be submitted on November 1st. Now it's submitted October 1st. It's difficult to get more than the first, or at best the second rotation of fourth year into the letter. So most schools actually don't have any fourth year information in the letter anymore. And just sort of given the longitudinal and comprehensive nature of the MSP, it's difficult to see what another assessment sort of before the match actually sort of adds to that. And it becomes, I think, another potential stress point for students once they sort of have assumed that they're all done. So the editorial part of this is that we're awash in information. And information drives all sorts of things. And information, it not only drives commerce, it actually in many cases is commerce. Information, whether it's sort of accurate or not, drives public discourse. It drives our political system. And the problem we have, one of the problems we have is that we confuse information with knowledge. We assume that if we have enough information that we know what we need to know, and that's generally hardly ever the case. We also have a tendency to look for things that we can measure. Again, I mean, I think this comes from a good place, but when we find things we can measure, we make a concerted effort to measure them accurately, and then we decide that they're important without making an assessment beforehand which things are really important and how well can we measure those things. And so we have a situation where the route to residency is pretty well defined, but again, this is involved with a thirst for knowledge. We tend to look around for things that we can add because we think that sort of more information adds more value. And so what we end up with is a landscape that's potentially very cluttered. I mean, just in the last few years, just in the last couple years, we now have standardized video interviews. I'm sorry, but I have absolutely no idea whose idea that was. But I think it is one of the worst ideas I have ever heard. And I can go on. Well, I won't go into why in this forum. But I will say editorially that I'm pretty sure it wasn't created by anybody who looks like me. But that's just another comment. It is. We have requirements now that students have to do away rotations in certain disciplines because for some reason, all of a sudden, the information that's generated during their sub-I experience at their home institution isn't accurate enough. They have to have information from an outside institution. And so there's all this sort of churning that goes on. And I see this additional competency evaluation of students post-match as another part of that churning, just looking for information, because we think that more information will provide more clarity, when in many cases it actually doesn't. So that's my story for the moment.
Hey, thank you. I am Helen Morgan, and I had nothing to do with the standardized videos. I'll put that as in my first disclosure. And I know that I have the very coveted last talk before lunch spot, so thank you. Let's see. I am an associate professor in OB-GYN at University of Michigan, and I want to start first by thinking about match day. About 3 weeks ago, I love match day. We now know the president of Brown University, Christina Paxson, she loves match day. My cheeks always hurt from smiling so much. Out of curiosity, like how many people here went to match day this year? Raise your hands. Okay, so lots of people went to match day. Now, I'd also like you to raise your hand if you can think of a student who matched at match day this year, who's going to start residency and they are going to thrive. You know they're just going to hit it out of the park. Raise your hand if you can think of a learner who's going to start residency so strong. You can guess what my next question is. Now, raise your hand if you can think of a student who matched on match day, 2018, who's going to start intern year, and they are going to struggle on day one. They are going to struggle their first month. They're going to struggle their first 6 months of residency. So, and I also want you to think about what was that last year of medical school like for the student who's going to thrive in thrive during their intern year, and what was that final year of medical school like for that student who's going to struggle, and should they be different? So my goal for the next 15 minutes is to talk about how reporting information after the match can provide a very learner-centered way of transmitting information, and it can also finally provide the impetus for rethinking what should the curriculum and what should the assessments be of that last phase of medical school. I'm going to start first with timing. Like Dr. Henderson alluded to, the medical student performance evaluation is transmitted on October 1st, and for all intents and purposes, the information is gathered in July or August. So you have 10 or 11 months of the final bit of medical school that right now is unaccounted for. And there is a lot of growth, and there's a lot of development that happens during that final phase of medical school. Students are taking their sub-internships, students are taking career electives in the career that they want to go into. They are performing really impactful research in the clinical setting, in the non-clinical setting, thinking about work in free clinics, and we're not accounting for it right now, and that word accountability is a word that I'll get back to later in the talk, especially in the context of honest accountability. Timing's one thing, but really thinking about what we've been talking about all morning, getting to right, how are the assessments in competency-based medical education going to get us to that point is really the more important point. This is a powerful diagram from the Health System Science textbook. The light blue triangle are current student priorities: to take basic and clinical science courses in order to get the best grades possible, the best step exam scores possible, in order to match into the best residency program. We aspire for our students to have the priorities in the dark blue triangle on the right. we aspire for our students to take a balance of clinical, basic health system science courses in order for them to develop patient-centered skills in order to become the best doctor possible. And we've already talked about how assessment drives the learning. And right now, most of our assessments have been centered around the light blue triangle of norm-referenced assessments that provides norm-referenced data, whereas we aspire toward how can we get towards that dark blue triangle of more criterion-referenced data. The challenge, of course, is the reality of the match and the match system right now. Bridget O'Brien has been talking and recently had a publication in Academic Medicine about kind of issues with transition to residency. And she cites the statistic that in the 1950s, there were 6,000 applicants vying for approximately 10,000 positions. In 2017, we had 35,900 applicants vying for 31,000 positions. And everybody knows that our program directors right now are receiving hundreds and hundreds and hundreds of applications for 5 residency spots. So program directors need that norm reference data in the light blue triangle in order to determine who they're going to interview and who they're going to put on their match list. Medical schools also are disincentivized to provide truly transparent information that could hamper their students' chance for matching. So the crux of my argument really is that we want to be able to move towards that dark blue triangle away from the light blue triangle. And what Dr. Madera talked about this morning with intrinsic versus extrinsic motivation and how are we ruining our students by focusing too much on the extrinsic motivation of the light blue triangle, and how can we evolve more towards the intrinsic motivation that brought them to medical school in the first place. So at Michigan, we have been reporting competency information after the match. We have 4-week residency prep courses in the spring, right before graduation, so February and March before they graduate in May. So we had this idea back in 2015, 2016, could we take criterion reference data, criterion reference assessments from the residency prep courses, supplement them with some of the medical school assessments, and then we mapped them to the ACGME entry-level milestones, which were also released right around that 2013, 2014 time. And so we mapped them to the surgery, OB-GYN, and pediatrics entry-level milestones, and we've been sending these educational handover reports to program directors since 2016 in these specialties. Here's an example of one of the letters that we sent for one of our general surgery students. We have some narrative comment on the left and then a table with their ACGME entry-level milestone information on the right. So here's a sample of the text that we sent for one of our students. This student stood out for his laparoscopic technical skills. His areas for development include his data gathering and critical thinking skills. And then you can see in the table here, it complements what the narrative comment says. So for this student, in the competency domain of patient care, in the subcompetency for care for diseases and condition, this student had a -1 for further improvement, which kind of builds with his areas of development there, whereas in the performance for operations and procedures, he was rated a 1 for proficient for an incoming intern. So there's a lot of concrete information in this report. And then we published this month our paper about what do program directors feel about this. And so we surveyed program directors from surgery, pediatrics, and OB-GYN. And the program directors felt that this provided better level 1 competency information over the MSPE. Whenever I talk to people about what we're doing at Michigan, people ask, what about buyer's regret? Are you worried that program directors are going to see your report that you're sending them and experience buyer's regret for the person they just matched? And I think that in 2018, we're at the point that we have to start getting past that for 2 main reasons. One, of course, patient safety, and patient safety, because our interns remain the front line of patient care. And then equally important, learner safety. Our learners want to know where they need to work on things, and we're not doing them any favors because it will come out, maybe not on day 1 of residency, but 2 months into residency or 4 months into residency when these issues do arise. But it's not just the data, it's what we do with the data, as Stan said. So I think that we really need to think very intentionally at the medical school and residency level about coaching and advising, and what we're doing here in the consortium of trying to change the culture so that from the beginning of medical school, students feel empowered to talk about their areas for development. I've delivered many, many babies with new interns, and I have not had that conversation where a new intern says to me, this is what I'm working on, can you help me get to this level? And that's where we need to get to with better coaching and advising. There needs to be, of course, curricular flexibility at the medical school and the residency level. There's very few times in medical education where there's curricular flexibility, except for the entire fourth year of medical school. There's so much flexibility there, and we should be taking advantage of that. At Michigan, we have been having a lot of advising, and we have a clinical competency committee for our fourth year students to holistically look at what they need in order to get to that point where they will do well on day one of residency. And then, of course, curricular innovation. When we think about all the topics of health system science that really straddle the UME-GME divide, how can we start thinking about new ways of delivering the content? How can we think of new ways of developing rigorous assessments so that we can improve this transition point? So 1 year ago at this AMA consortium talk, George Thibault talked about how this was a propitious time to implement the theories of competency-based education into practice. And I would argue that this reporting of competency information after the match is a way of improving communication with accountability and with honesty, and it actually creates a continuum of learning for our learners so that they will thrive during those months after match day. Thank you.
Actually, Dr. Morgan, there is much that we agree on. Can you go back to the slide where you had career advising and coaching?
Yeah.
Thank you. I mean, all these things are actually really very important. I think there are differences in sort of how we look at things. I agree with your comments about patient safety, and it sort of draws my mind back to something that Dr. Madara said about redefining and reframing problems. And so we assume we have an education problem, but we actually have a patient problem because at both the UME level and the GME level, we are educating people to take care of patients. And our patient population has changed drastically and will continue to change. But in many ways, we're still educating everybody and the way we have traditionally across schools in the country. I mean, the people who represent institutions in this room may be somewhat different, but for the most part, I mean, most schools are still doing things the way they have done them. And the manner in which we are bringing people in to medical schools and residency programs really hasn't changed that much if you sort of look at who is sort of sitting in conference rooms from time to time. And the manner in which our system is structured is based on certain assumptions, certain perspectives, and certain preconceptions in some ways. And so I think my point is that we don't need a lot of new and different assessments. We need to sit down and have, I think, a very thoughtful conversation about what our goals are, about exactly what it is we're trying to accomplish. And once we can come to some reasonable agreement on that, then go back and try to figure out exactly what it is we need to measure. When I first started as a faculty member, one of my jobs was to provide a clinical assessment of our new interns. It was usually done the first week. We took them to our clinical skills department in the school. There was a special program set up for them. We assess them in much the same way that we did our students, in addition to some technical skills. I mean, so most of this can be done on a GME level. I think maybe more accurately than we can do it on a UME level, because what a surgery program is looking for is going to be different than what a psychiatry program is looking for. And so I think assessment like this is important. I'm not sure it just belongs in medical school, because I think we're already sort of cluttered with assessment. And again, we need to figure out what's meaningful. So essentially, David D. Henderson is calling for a total ban on assessment until somebody can figure out what the hell is going on. Thank you.
I think that oftentimes we do get fixated sometimes on some of these details of, well, what language should it be in? Should it be ACGME? Should it be EPAs? Should it be specialty specific? Or are there some core characteristics of all of our graduates that we expect? And these are all very important questions that we need to grapple. But we all know which students are going to struggle, and we all probably have a great sense of in which competency domain they are going to struggle in. And we know, but we're not really telling them. And so then they are starting their residency overwhelmed, because we all know that residency is a very overwhelming time where you're trying to figure out where the bathrooms are and where your ID badge is. And so I contend that there is a great opportunity at the end of medical school to provide this information, whenever that end may be, that we should aspire for time variable, competency-based education, but no matter what that time is, there still needs to be this communication at the end of it in order for it to be a continuum. And we've been doing this for 3 years, and their students are so diverse in what they need and what their areas of development are, and just having the coaching conversations, having the advising conversations, having the students develop their IDP so that they know what they're working on. Again, regardless of what language we choose, I think will be the really meaningful part of creating this new communication.
Great. Well, I wonder if we can end just by giving all of our presenters another round of applause for doing a fantastic job.